Tunaweza kuinnovate kwa kutumia maji la hela nyingi sana.
Majina ya Haitebo.
Haitebo. Kwanza nataka kuongea na DC.
Kama unatoka sasa hivi. Kwa zamani ya papa na boss hapa kuondoka sasa hivi.
Mwisho wa rais.
Sasa kwa Afrika ndio maana siku moja basi.
Niseme pia. Sasa pia kwa sababu tunapata something yake.
Wameshaongea na watu, wameshaongea na watu.
Kama anatoka.
Yaani tunaweka nipate kwa sababu alikuwa anataka mdada, alikuwa anataka mama balance nenda. Ndio alianza kunipigia simu toka na nini?
Sema watu kama walimu machukio.
Alianza kunipigia toka kiko kwa sababu ya nini?
Kibusi.
Kuna kisi wapo moto unaweka kumbe
Bora, naona mwitikio mdogo.
ya na kesho sababu kesho natamani nadhani watu watakuja kesho watakuja watu kama tunawashinda kwa nini washinda watu I will believe kwamba
nani sio nzio
sijui siku leo I will believe kwamba now officially over. Chakula ni nje. Chakula ni hali tatu mtapata chakula.
Naona ndio sasa chakula tunashika. Lakini
mimi nilikuwa naongea ndio nilikuwa naongea pata kati mnakula sasa. Naona kwamba mnakula. Tapateni comments.
Amekula chumvi hapa. Mara sangapi? Mara sangapi?
Habari za mchana. Tukaribia, naomba niombe samahani kwa kuchelewa kuanza kwa muda mchache uliopita. Ningeomba wafuatao waje kwenye meza kuu ili tuweze kuanza na shughuli yetu ya ufunguzi. Ningeomba makamu mkuu wa chuo aje mbele pamoja na makamu na wasaidizi wake wawili kwa upande wa academic, Deputy Vice Chancellor Academic na Deputy Vice Chancellor Planning, Finance and Administration. Ninamwomba mwakilishi kutoka UDSM, tawi la Mbeya, Profesa Posi mbele. Namwomba pia na mwakilishi kutoka UDOM, Dr. Kibusi, ya karibu sana kwa mbele. Asante sana. Makamu mkuu wa chuo kikuu cha afya na sayansi shirikishi Muhimbili, manaibu makamu mkuu kwa upande wa taaluma, utafiti na utafiti wa kitaalamu na ushauri wa kitaalamu, na naibu makamu mkuu kwa upande wa fedha na mipango. Mwakilishi kutoka University of Dar es Salaam ambaye ni tawi la Mbeya ni Profesa Posi. Mwakilishi kutoka chuo kikuu cha Dodoma ni Dr. Kibusi. Wakuu wa idara, wakuu wa skuli, wakurugenzi, watoa mada wetu wa leo, wanafunzi, wanahabari wote, na wasalimu kwa jina la Jamhuri ya Muungano wa Tanzania. Karibuni sana katika siku yetu muhimu ambayo tumekuwa tukisubiria, siku ambayo tutakuja kuongelea kuhusiana na miaka 60 ya uhuru kwa upande wa afya, ambapo hasa tutajikita katika kuongelea mwenendo wa magonjwa na mwitikio wa sekta ya afya hapa nchini. Kongamano hili limeandaliwa kwa kushirikiana na MUHAS, Chuo Kikuu cha Afya na Sayansi Shirikishi Muhimbili, pamoja na Chuo Kikuu cha Dar es Salaam kwa tawi la Mbeya ambao wao wanafanya afya, na Chuo Kikuu cha Dodoma kwenye upande wao pia wa afya. Karibuni sana. Kuna watu wa mada wazuri ambao wataweza kufanya siku ya leo na kuweza kuwa na discussion nzuri sana. Sasa bila kupoteza muda, naomba nimkaribishe makamu mkuu wa chuo, naibu makamu mkuu wa chuo cha afya na sayansi shirikishi Muhimbili kwenye upande wa taaluma na utafiti, Profesa Kamwaba aje atoe salamu za ukaribisho. Karibu sana.
Makamu mkuu wa chuo, naibu makamu mkuu wa chuo, wawakilishi kutoka chuo kikuu cha Dodoma na chuo kikuu cha Dar es Salaam, waadhiri, wanafunzi, wafanyakazi na wanafunzi, karibu sana katika kongamano letu hili ambalo ni kongamano mojawapo katika kuadhimisha miaka 60 ya uhuru wa Tanzania. Sisi kama taasisi ya serikali kushirikiana na chuo kikuu cha Dodoma pamoja na chuo kikuu cha Dar es Salaam tumepewa jukumu la kuwa na kongamano na kuangalia mwenendo wa magonjwa pamoja na mwitikio wa sekta ya afya kwa miaka 60 tangu kupata uhuru mpaka saa hizi. Kama tunajua chuo kikuu Muhimbili ni chuo kikongwe katika kutoa mafunzo huduma za afya hapa nchini, lakini vile chuo kikuu cha Dar es Salaam kina tawi la Mbeya, lakini chuo kikuu cha Dodoma vile vile kinayo koleji ya afya. Kwa hiyo tunashirikiana katika kongamano la leo. Ratiba imetolewa ambayo itaonyesha mada zitakazowasilishwa na watoa mada watatu, then tutakuwa na panel discussion. Baadaye tutakuwa na mijadala, maswali na majibu. Kama alivyotangulia kusema MC ni kwamba tumechelewa. Tutaomba sana wale watu wa mada au kutoa salamu tuwe kwa kifupi sana, lakini lengo ni kufikisha ujumbe kwa wananchi kupitia kongamano hili, sasa kwa vyombo vya habari ambavyo tuko hapa, kuona ni hatua gani tumepiga kama taifa katika kukabiliana na magonjwa. Na sasa tutaangalia mchango wa sisi kama vyuo, taasisi za elimu ya juu. Kwa hiyo kwa maneno hayo, naomba sasa nimkaribishe makamu mkuu wa chuo kikuu cha Afya na Sayansi Muhimbili, Profesa Andrea Pembe. Okay, nimeambiwa kwamba tutaanza na wawakilishi kutoka vyuo vya wenzetu. Kwa hiyo tutaanza na wawakilishi kutoka chuo kikuu cha Dodoma. Karibu sana, salamu za chuo.
Asante Profesa. Mheshimiwa makamu mkuu wa chuo, Mheshimiwa manaibu wa makamu mkuu wa chuo, mwakilishi kutoka University Dar es Salaam, ndugu na jamaa, habari za mchana. Nasimama hapa mbele yenu kutoa salamu kama mwakilishi wa University of Dodoma, lakini labda specifically niseme kwamba Profesa Faustin Mbe ambaye ndiye makamu mkuu wa chuo kwa University ya Dodoma, lakini pia anawakilisha jumuiya ya wanataaluma kutoka college skuli mbili za afya, the School of Nursing and Public Health and the School of Medicine and Dentistry. Tunayo furaha kubwa kwa hapa na ni heshima kubwa sisi ambao kwa kujilinganisha kozi kiongelea swala la afya bado ni newcomers. Kwa hiyo it's a privilege to be here, and we thank of course the Ministry of Education for thinking of us, and including us in the team of celebrating the independence of our country by looking at the achievement that we made tangu tulipopata uhuru hadi leo. Kwa ni discussion moja muhimu ambayo kwa kweli kushiriki kwetu pia tunaona kwamba ni jambo la muhimu, na tunashukuru kwa nafasi hii kuweza kushiriki katika jambo hili. Zaidi natarajia mazuri zaidi yatatoka katika discussion, na labda anaweza kusaidia kwa namna moja au nyingine kuweza kushape the future ya sekta ya afya hapa nchini. Asante sana.
Dr. Kibusi, naomba ni mwakilishi kutoka chuo kikuu cha tawi la Mbeya, Profesa Posi. Karibu sana. Makamu mkuu wa chuo na wenzangu wote wahadhiri, nikisema itifaki imezingatiwa. Kwanza niseme nimefurahi sana kuwepo hapa leo, kwa sababu mkuu aliniambia niende nikawakilishe chuo chetu cha Dar es Salaam ndani ya Mbeya kwenye sayansi shirikishi na mengine mengi. Lakini kikubwa pia kwamba tumekuja hapa tukisema kwamba sisi na Muhimbili ni kitu kimoja, kwamba tulitokea katika mzizi mmoja, tulikwenda pamoja mpaka tukafikia tangu mwaka 63 tunaanzisha, tulikuwa wote pamoja, ikaja 68 69 tukaenda pia Dar es Salaam, ikawa katika sehemu nyingine, tukaenda mpaka kufikia hapa tulipofikia leo. Na sasa leo tumefikia wapi? Sisi tuko ndani kule Mbeya, lakini tumeanza tu mwaka 2014. Kwa hiyo tunajitahidi kabisa, na tutasema leo hapa ili tuweze kushirikiana kuona yale ambayo tumeyafanya kule tulikotoka na huko tunapokwenda, ili tuweze kujua tunafanya nini. Ningetamani kabisa vijana wote mkaona na kuona kwamba huu ni mfano wa kuigwa wa pamoja. Kwa mfano vile hata wenzetu wa UDOM wote tunatoka pamoja na tunajenga nchi moja na tuko katika tasnia moja. Kwa hiyo ni furaha yangu kubwa kuona kwamba tuko leo pamoja, tujue tumetoka wapi, tuko wapi na tunakwenda wapi. Kwa hiyo nasema kwa niaba ya mkuu kwamba Tuko pamoja na karibuni tuendeshe gurudumu la afya. Asanteni sana.
Asante sana Mheshimiwa kutoka Chuo Kikuu cha Dar es Salaam tawi la Daki ya Mbeya. Sasa naomba nichukue nafasi hii kumkaribisha mgeni rasmi ambaye ni makamu mkuu wa chuo cha Muhimbili aje afungue rasmi kongamano hili. Karibu sana Profesa Tembe kufungulia kongamano.
Habari za mchana. Habari za mchana. Afya kidogo imeonekana. Mimi si mgeni rasmi, lakini nimesimama hapa kwanza kabisa kwa niaba ya Waziri wa Elimu, Sayansi na Teknolojia Profesa Joyce Ndalichako, pamoja na mkuu wa mkoa wa Dar es Salaam na Amos Makala katika siku ya leo. Bahati mbaya wameshindwa kufika hapa kwa majukumu mbalimbali ambayo wamekabidhiwa, lakini kama ambavyo unaona mabadiliko yakiwa yanatokea kwenye makongamano mengi, kwa ajili ya kazi hizi kama waziri zilizonazo katika wiki hii, iliamriwa kwamba wakuu wa mikoa waweze kusaidia katika kufungua makongamano haya. Lakini kwa bahati mbaya kulikuwa na mkutano mwingine mkoa wa Dar es Salaam ambao unahitaji maamuzi ya mkuu wa mkoa, hivyo akashindwa kufika. Dr. Steven Kibusi, mwakilishi wa makamu mkuu wa chuo kikuu cha Dodoma. Niko najua ukishakuwa profesa, na sijui kama nilisoma vibaya ile tangazo. Asante sana. Profesa Mwajabu Kosi, mwakilishi wa mkuu wa chuo kikuu cha Afya na Sayansi Shirikishi Mbeya, chini ya chuo kikuu cha Dar es Salaam. Profesa Pernali Kamuhaba, makamu mkuu wa chuo kikuu, kaimu naibu na makamu mkuu wa chuo kikuu Taaluma, Tafiti na Ushauri. Profesa Saidi Abud, kaimu naibu wa makamu mkuu wa chuo Mipango, Fedha na Utawala, chuo kikuu cha Afya na Sayansi Shirikishi Muhimbili. Wakuu wote wa skuli na kurugenzi ambao wako hapa, wakuu wa idara, viongozi wa serikali na taasisi mbalimbali ambao mko hapa, maprofesa, wahadhiri, wanajumuiya wote wa chuo kikuu cha Afya na Sayansi Shirikishi Muhimbili, wanahabari wote, wageni waalikwa, mabibi na mabwana. Kwa niaba ya vyuo vikuu vya afya vya chuo kikuu cha Afya na Sayansi Shirikishi Muhimbili, chuo kikuu cha Dodoma na chuo kikuu cha Dar es Salaam, kupitia chuo kikuu kishiriki cha Afya na Sayansi Shirikishi cha Mbeya, ninayo furaha kubwa kuwakaribisha na kuwashukuru wote wageni waalikwa, viongozi wa serikali, viongozi wa taasisi mbalimbali za serikali na zile ambazo si za kiserikali, na washiriki wote wa kongamano hili. Mmetupa heshima kubwa ya kukubali kuja kushiriki nasi katika kongamano hili na kuadhimisha miaka 60 ya uhuru yenye dhima isemayo miaka 50 ya uhuru, mwenendo wa magonjwa na mwitikio wa sekta ya afya nchini. Kufika kwenu hapa leo ndio mafanikio ya siku hii muhimu sana. Sote wadau katika afya na pia watumiaji wa sekta hii, karibuni sana. Ndugu wageni waalikwa, washiriki, mabibi na mabwana, awali ya yote napenda kuchukua nafasi hii kuipongeza serikali ya Jamhuri ya Muungano wa Tanzania chini ya uongozi thabiti wa Rais Mama Samia Suluhu Hassan kwa kuona umuhimu wa kuwa na makongamano haya katika sekta mbalimbali ili tuweze kujadili na kutafakari kwa pamoja wapi tumetoka, wapi tumefika na wapi tunaelekea katika taifa letu la Tanzania, kuanzia pale ambapo tulipata uhuru miaka 60 iliyopita. Tafakuri kama hii inatusaidia sisi kama wadau katika sekta mbalimbali nchini kuweza kuona wapi tumefanya vizuri, wapi tulipokosea na wapi tunahitaji kuweka msisitizo zaidi ili kufikia malengo tuliyojiwekea kama taifa. Pekee kabisa, napenda kutoa shukrani zangu za dhati kwa serikali kupitia Wizara ya Elimu, Sayansi na Teknolojia kwa kukiamini Chuo Kikuu cha Afya na Sayansi Shirikishi Muhimbili na kukasimisha jukumu la kuratibu kongamano hili la miaka 60 ya uhuru kwenye sekta ya afya nchini, tukishirikiana na Chuo Kikuu cha Dodoma na Chuo Kikuu Kishiriki cha Afya na Sayansi Shirikishi cha Mbeya chini ya Chuo Kikuu cha Dar es Salaam. Kwa sisi kama Chuo Kikuu cha Afya, tulipokea jukumu hili kwa heshima kubwa na kulitekeleza kwa ufanisi mkubwa mpaka hapa tulipofikia siku ya leo. Ndugu wageni waalikwa, washiriki, mabibi na mabwana, niruhusu niongee kwa ufupi kuhusu Chuo Kikuu cha Afya na Sayansi Shirikishi. Chuo hiki kilianzishwa mwaka 1963 kama skuli ya tiba ya Dar es Salaam, Dar es Salaam School of Medicine, katika eneo iliyokuwa inaitwa hospitali ya Princess Margaret. Miaka miwili tu baada ya Tanganyika kupata uhuru. Kuanzisha kwa skuli hii ilikuwa ni juhudi maalum ya kimkakati iliyofanywa na serikali ya awamu ya kwanza chini ya Rais hayati Mwalimu Julius Kambarage Nyerere ili kuongeza uzalishaji wa madaktari nchini na kuweza kuleta mageuzi ya kasi kwenye sekta ya afya hapa nchini. Katika kipindi cha takriban miongo 6, Chuo Kikuu cha Afya na Sayansi Shirikishi Muhimbili kimekuwa kutoka kitengo chenye wanafunzi 10 mpaka kufikia chuo kikuu ambacho kina programu 101 na kwa wakati huu kina jumla ya wanafunzi 4,500. Na hawa wanajumuisha wale ambao wastashahada, shahada ya kwanza na shahada za uzamili na uzamivu. Ndugu wageni waalikwa, washiriki, mabibi na mabwana, kwa ajili hiyo Chuo Kikuu cha Afya na Sayansi Shirikishi Muhimbili kimeendelea kukua na kupanua mazingira ya ufundishaji na utafiti, huku ikichukua nafasi kubwa katika kutoa ushauri wa kitaaluma kwenye masuala ya afya kwa taasisi mbalimbali, serikali yetu na kwa jumuiya ya mataifa. Mwaka huu tena tunategemea kuadhimisha hatua nyingine muhimu ya kukamilisha kwa awamu ya kwanza ya ujenzi wa kituo cha umahiri cha magonjwa ya moyo na mishipa ya damu cha Afrika Mashariki, yaani kwa Kimakonde ni East African Center of Excellence in Cardiovascular Sciences katika campus ya Mloganzila. Kituo hiki kitafunguliwa rasmi siku ya Jumatatu tarehe 6 Disemba na Mheshimiwa Makamu wa Kwanza wa Rais wa Serikali ya Mapinduzi ya Zanzibar. Kituo hiki kitatoa mafunzo na kuzalisha rasilimali watu katika taaluma bobezi, yani specialists and super specialists za moyo na mishipa ya damu kwa nchi za Afrika Mashariki. Hii inaonyesha kwa kiasi gani kama nchi tumeweza kupiga hatua katika kipindi hiki cha miaka 60 ya uhuru, hasa katika mafunzo ya wataalamu wa afya hapa nchini. Napenda kuchukua nafasi hii kuwakaribisheni wote kwenye sherehe hizi muhimu za ufunguzi wa kituo hiki zitakazofanyika katika kampasi ya tarehe 6 Desemba saa 3 kamili asubuhi, na karibuni sana. Ndugu wageni waalikwa, washiriki, mabibi na mabwana, mimi leo si msemaji na nisingependa kuwachosha maneno mengi, lakini naomba nichukue muda huu mchache kutoa shukrani zangu za dhati kwa kamati ya maandalizi ya kongamano hili lililoongozwa na mkurugenzi wa utafiti na machapisho wa chuo chetu kikuu cha afya na sayansi shirikishi Muhimbili, Profesa Bruno Sunguya, ambayo pia katika kamati hii tulikuwa na wajumbe kutoka katika chuo kikuu cha afya na sayansi shirikishi cha Mbeya chini ya chuo cha Dar es Salaam, na vile vile kutoka chuo kikuu cha Dodoma. Tunawashukuru sana kwa kujitoa kwao kwa hali na mali juu ya kuhakikisha kongamano hili linafanya. Kamati imefanya kazi kubwa, ninawapongeza na kuwashukuru mno kwa moyo huo wa kujitolea. Asanteni sana. Naomba nichukue fursa hii kusema kuwa kwa niaba ya Waziri wa Elimu, Sayansi na Teknolojia Profesa Joyce Lazaro Chako mbunge, na kwa niaba ya mkuu wa mkoa wa Dar es Salaam Mheshimiwa Amos Makala, ninatangaza kuwa kongamano hili limezinduliwa rasmi. Asante sana.
Asante sana makamu mkuu wa chuo kwa kutufungulia kongamano letu. Naomba pia tuwapigie makofi wote walioongea sasa hivi hapa meza kubwa. Sana kwa maneno walioweza kutupa ya hekima. Sasa ningeomba meza kuu washuke chini sasa hivi ili tuende katika mada zetu. Karibuni mshuke chini ili tuendelee sasa na mada zinazofuata. Asante sana. Wakati wanashuka chini, naomba nimkaribishe mtu wa mada wetu wa kwanza ambaye atakuwa ni Professor Emeritus Jafet Kileo, ambaye atakuja kutoa mada yetu ya kwanza ambayo inaongelea Epidemiological Transition from the pre to post independence, how the 60 years of independence predicts the future of Tanzania. Karibu sana Profesa. Na kongamano letu mada zetu tumesema unaweza kuongea Kiswahili. Sio kwa Kiswahili kwa sababu ni kwa watu wote wa Tanzania wanatakiwa kusikia na waweze kuelewa linaloongelewa hapa. Karibu sana Profesa.
Welcome, ladies and gentlemen. Vice Chancellor, DPC ACTS, representatives from Europe, representatives from University of Dar es Salaam branch, invited guests, ladies and gentlemen. I've been asked to talk about this topic of transition, epidemiological transition from pre and post independence, and how the 60 years of independence predict the future. English Swahili is something I enjoy talking about, but there are certain terminologies I fail to translate. This is a keynote address, which is delivered in this symposium on the 1st of December 2021. First of all, I would like to say that the transition in epidemiology is why you wanasema epidemiolojia. Nimekaa na epidemiology miaka mingi, hiyo sijapata translation yake, lakini najua ni epidemiolojia jinsi magonjwa yanavyoenea baina ya watu. I cannot avoid talking about the following: population increase and how it has affected the epidemiological transition, the unchanging population age structure of Tanzanians, the slow economic development, inadequate investments in health, and inadequate investments in education, and lack of good governance. These are issues that go hand in hand with the epidemiological transition of diseases in Tanzania and in many other countries as well. So I'll just talk about the most important ones because we have a time constraint. This is a very simple graph, and it shows how our population in Tanzania has been increasing with time. This is exponential in nature, and it means the population has been increasing exponentially, and the attendant epidemiological situation in the country. This population increase will lead to many things. But a few of them are that we must feed the people. The increasing population, we must feed it, and we must produce enough food to feed the population. And here's just an example of how the population has been consuming animal meat production and other food items. And here, eggs, meat, increasing also exponentially, just like the population has been increasing since 1961 up to now. And then dramatic increase in land use and agriculture. For agriculture, we have to produce food, and so you can see from 1700, that is pre-independence, long time ago, there was hardly any agriculture in the globe. And then in the year 2000, some brownish agriculture emerged, and it is estimated that in 2050, almost everywhere it will be agriculture, and food will be plentiful if we are keeping the same rate of increase of the population. How does that affect our health? The dramatic increase in land use for agriculture leads to deforestation, which is not nice, encroachment of wildlife habitats. Human beings go into the wilderness, they encroach the wildlife habitats, and then emergency of new disease threats, particularly zoonosis, they will occur if we encroach on the wildlife habitats. The changes that have been taking place post-independence are many. There's little is known now about the epidemiology and profile pre-independence. Before independence, we really have very little information about the epidemiology of diseases in Tanzania. But after 1961, Tanzania declared war against three enemies: poverty, disease, and ignorance. I think many of you are aware of this, and the late President Nyerere was very much behind this. However, the enemies are still with us today, but maybe not as much as it was at that time. Evidence shows that poverty has increased, all diseases have persisted, and new diseases have surfaced. That is the reality. And although some of these diseases have been controlled, others are resurfacing. That's the biggest problem in Tanzania and in many other countries, particularly developing countries. Total fertility has been declining, but not as much as it should be. And then in Tanzania, early marriages, low contraceptive use, and desire for large families are the main determinants of high fertility and therefore the health of the people. Future sustained fertility is therefore dependent on breastfeeding trends, adolescent fertility, and increase in contraceptive use to reduce maternal mortality. These are conditions that we should be careful in terms of reducing morbidity and mortality in Tanzania. Important determinants, again, life expectancy at birth has increased slightly over time. You can see the graph growing. At one point in time, it was affected probably by HIV AIDS, and then infant mortality rate decreased from 152 in 1950 to 38 in 2020. And then the infant mortality rate decline has been attributed to immunization programs, good immunization programs in Tanzania. Then, quite related to the epidemiology of diseases in Tanzania is the human resource issue. Overall, the health workforce in Tanzania has shown an accelerated decline from 1990s, even though its population and disease burden has increased considerably. In 1994, for example, Tanzania had 67,000 health workers for 28 million people. And in 2001, the number had fallen to 48,000 workers for a population of 44 million people. And then in 2009, it had fallen to 25,000 healthcare workers for more than 40 million people. Likewise, in 2004, Tanzania was reported to have the world's lowest coverage of physicians, with only 0.2 graduate doctors, specialists per 1,000 people. So that is not a very good picture if we know that these are the people who are responsible for keeping the health of the people in good shape. And then we have shortages of human resources, 65% in 2006, 74% down the line, and then referral hospitals in urban areas had a very big shortage. And then in dispensaries, we had the biggest shortage of healthcare workers. And human resource issues, the shortage was due to a number of reasons, from limited number of training institutions in this country, although universities have been increasing in number, but this was a very slow process, low output of qualified personnel, and even distribution of healthcare workers in the country, low motivation for healthcare workers, inadequate physical infrastructure, and then poor management and difficult working conditions for some healthcare workers. Rapidly growing population, here again, is a big determinant, and HIV/AIDS pandemic and other disease burdens were responsible for making the human resource inadequate. And some brain drain has also taken place in this country, although not as much as in other countries, in neighboring countries. In mid-1980 to 2000, there were more than 10 years of employment embargo. I think most of you are aware of this situation, which was imposed by the National Monetary Fund, involving most public institutions, which resulted in the biggest deficit of human resource across all sectors. During the same period of time, emerging and emerging pandemics or epidemics demanded high quality trained personnel with epidemiological and laboratory skills to investigate, control, and institute surveillance measures. Luckily, during the same time, there was a field epidemiology and laboratory training program called Festive, which was to address some of these human resource issues. In 1977, this is now epidemiology of cholera. Most of you are aware of this disease. In 1977, an epidemic of cholera broke out in Tanzania, starting in a small village in the Rufiji Delta. This was the first ever epidemic throughout the country, as it spread into regions within a period of 5 years, affecting 55,000 people and causing over 5,000 deaths. The epidemic was difficult to control due to general lack of skills and also among the healthcare workers, and then the acute nature of the epidemic and lack of awareness among the people, general public, on how cholera is transmitted. This was in spite of availability of good diagnostic services, effective treatment, oral rehydration fluids, health education, and national environmental sanitation campaigns to construct the trees. Clean, safe water to drink at that time was not available in most places where cholera was occurring. And so that was a factor that kept cholera around. But you know, recently COVID-19 has helped in a way to make people wash their hands more frequently. So cholera is probably disappearing with the advent of COVID-19. The other epidemic was smallpox. Smallpox was one of the biggest health problems before independence, which continued for a while thereafter. Smallpox was certified, eradicated in 1979 worldwide, and Tanzania was part of this celebration, an achievement which saved the country from costly immunizations against smallpox. This success story encouraged Tanzania and other countries to invest in prevention through immunizations. However, the impact of this news soon waned as Tanzania waged a full-fledged war against the Amin of Uganda. The war devastated the economy of this country, which never recovered for many years ahead. So that is an important milestone. And then the epidemiology of HIV AIDS came, and AIDS was once a zoonotic disease, could be transmitted from animals, as it first emerged around the 1930s from animal origin. It was first recognized clinically in the US in 1981, and we are now witnessing 5 to 8 new emerging infectious diseases every year. And this number is going to increase to 30 new emerging infectious diseases by 2030, which is not very far from here. However, most of these emerging infections will be mild and undetectable, while a few will be serious pandemics like COVID-19. HIV/AIDS was the second most devastating epidemic in Tanzania after smallpox. And it started in Kagera region of the country, affecting productive segments of the population, while simultaneously creating orphans and vulnerable persons. The economy was disrupted as funds were directed
Yeah. So, and this was read by the then Minister of Finance, a British expatriate, Savase Green, and the government of Tanzania thought this was not a good plan since it didn't talk about agriculture or social services. Then they developed the Festive Plan. And this was the first plan that was between 1964 and 1969, with the aim, 3 key aims: increase per capita income from $55 to $125, complete Africanization, and then increase in life expectancy at birth from 35 to 50 years. That was the key areas that were focused. On the part of the health sector, it was mainly targeting infrastructure and human resource for health. And the aim was to establish a regional hospital in each region and build around 300 centers to serve 50,000 each and supervise 8 dispensaries below it. And to increase the enrollment of healthcare workers and to use new cadres to cater for large demand for healthcare workers. And that's where different cadres were introduced. Then there was a second 5-year plan that was between 1969 to 1974. And the main aim was to increase equitable distribution and access to health services and other social services, but with the aim of controlling communicable disease. And was aiming now to ensure that the health centers is reaching 50,000 people and a dispensary for every 10,000 people. And the third 5-year development plan, this was between 1976 to 1981. And this now intended to provide clean water and health services in urban and rural areas and establishment of universal health services. And this was a landmark because that was the period in which the Almata Declaration in 1978 with the goal of health for all was established. And during this period, the government had average health expenditure was around 6.4, sorry, not 60. So the policy of post-independent improving the health sector results into a lot of changes in the health sector between 1964 to 1980. But then came a recession in the 80s in which the country had to adopt the structural adjustment program. By adjusting this, this included reducing government So, the health services were adversely affected, leading to foreign retrenchment and hurting of employment, but also drugs for medicine and medical supplies and other essential items were reduced significantly. During that period, also the structures depleted, resulting in inadequate and poor quality services, and most of the post-colonial gains in the sector were best. To cover the severe shortage of funding for social services, the government then introduced the cost sharing that was capped in the health services. So then, during the era of 1990s to 2000, the main issue now was the health sector reform towards changing what has been invested. And the shortcoming experience including the strategic adjustment program with the aim of improving efficiency and accessibility of services to the communities. And the reforms were done hand in hand with providing the health services based on the principles of equity. The reform aimed at organizational, managerial, as well as financial reforms. And some of this included changing the laws, where we had now the Ministry of Health with responsibility, policy formulation, registration, declaration of quality, and quality control, while the Ministry of Local Government and Regional Authority was responsible with primary health care, that is district health center and dispensary services. And this devolution of power was very helpful, in which the council now provided authority to develop plans and budgets, including participation, but also new financing mechanisms were introduced, such as community health funds and the health insurance for civil servants. During this period, the average government health expenditure as a percentage of the total government expenditure was around 9%, which was a significant increase from the previous 10 years that had around 6.4% as an average. And the most latest has been Kukuta and the FYDP 1 to 3 that's being implemented now. And as a part of that, the health sector strategic 5 has been developed. And one of the most important things during this period has been the MAM, where is the primary health care service development program, now in Swahili as Mpango wa Maendeleo ya Afya Msingi, which has built quite a number of health centers from around 300 to 700, and district hospital for almost all the districts in Tanzania, and the dispensary have increased significantly. And this is some of the trends in the total government average expenditure as a percentage of total government expenditure from the 70s up to date. As you could see, we started at the 70s, around So as you could see, child mortality has gone down, but maternal mortality has remained unchanged. And that is not different with the fertility trends. We have only managed to reduce one child as an average since all that period, from 6.2 to an average of around 5.2, which is a little bit not impressive. While, as you could see, has resulted in significant population growth. So now what we would get from this is usually a blessing of a significant population growth, but you need to get a reward from that as a demographic dividend, in which you need to translate that growth from short lives and then have smaller families from larger families, and also you can change in better living standard families with high income per person, the dividend that you can get. But also long-term fertility decline is the most important factor for accelerating and amplifying the demographic dividend. And the declining fertility opens up the window of opportunity for the dividend. Access to voluntary rights-based family planning coupled with improved health and lowered desired family size will lead to achievement and the growing share of working adults. As you could see here, the change 60 years. You could see here, this is 1960, and this is 2012, the last census. And we see it is almost the same. We had the same structure with Malaysia in 1960, and you could see they have now a very constrictive pyramid, which has shown that they now gain a lot from that demographic dividend. So what is the future of Tanzania given the situation the past 60 years? One, we should prioritize human capital development. In that, improving adolescent health and productivity. Because we have a large number of adolescents, we need to ensure that we improve their health, but also we improve their education and productivity. And at the same time, improving the age structure by lowering fertility and increasing access access to family planning. But also improve education to girls and prevent early marriage and delay adolescent pregnancies. But also improvement of economy through poverty reduction, skilled workforce, access to microfinance services, and private sector involvement is key in the next years that come. And the combined investment approach in the economy, education, and family planning could possibly impact on demographic dividend, as we have seen previously. And some numbers shows that we could triple our GDP if that is being done. So in conclusion, Tanzania is still in the initial stages of a demographic transition. Despite consistent economic growth, we haven't really much from the demographic dividend. Birth rate is significantly bigger than death rate. This implies an increasing population, reducing the impact of economic growth to the people. But also striving for constructive population pyramid will increase the ratio of working age adults relative to young dependents. And that will be key to the next generation of our economy and health services. Thank you very much.
Sana Dr. Bravo. Now I would like to welcome Professor Daniel for the keynote address. The slide one. Aribusan is going to talk about the role of university in addressing local and global health challenges, the impact of transformative health training in Tanzania. Aribu, Professor Daniel.
Ladies and gentlemen, good afternoon. Na salimu kwa jina la Jamhuri ya Tanzania. Asante. The title of my presentation is the role of universities in addressing local and global health challenges, with a focus on the impact of transformative health training in Tanzania. I will talk generally targeting all universities of health sciences in Tanzania, but certainly I will draw a lot of my presentation from our experience at MOHAS. Ladies and gentlemen, that will be the outline of my presentation. I will take you through all those listed subtopics. And then let me start with the historical overview. As we are all very much aware, during the colonial aim of health professionals was almost non-existent. And whatever kind of training that was available was for the purpose of producing human labor for production, and provision of healthcare was for the purpose of ensuring availability of healthy people for production. Now, when European missionaries came, they established institutions to facilitate spread of religion, and they also introduced a healthcare package as simply to cater for the suffering as a core of their obligation as missionaries. And all healthcare professionals who were trained were foreigners. And during the two world wars, a need arose for having healthcare professionals, particularly for the native soldiers who were recruited to fight for the colonial masters. And these were trained to dress wounds largely, and we are very familiar with what was called tribal dressers, who were just trained to dress wounds, but they had no training for making diagnosis of diseases or, in fact, treating people who were sick. Also, immediately pre-independence period, the country was affected by a number of diseases, and it was quite clear that there was a demand for trained health professionals, and therefore training centers were established, cadres, medical aids in particular, and the first Tanzanian university-trained health graduates were in the 1940s trained by then at Makerere University College, which was a constituent college of the University of London. In 1961, Dar es Salaam University College started, and this one was also affiliated to the University of London. I'm sure can you come and help? Problems of study. For the interest of time, let me just say that between 1963 to 1967, we had the so-called Dar es Salaam Medical College. This was a college for training mid-level professionals, equivalent to what we now call clinical officers. Then in 1968, a faculty of medicine was established under the Dar es Salaam College, which was a constituent college of the University of West Africa. This faculty continued to exist until 1970, when the University of Dar es Salaam was established by an act. And the faculty naturally became the faculty of the University of Dar es Salaam. Now, the University of Dar es Salaam was established as a national university, and it had three major objectives. One, transmitting knowledge from one generation to another. Secondly, to foster creation of knowledge through research. And the third one was to train high-level professionals for the various disciplines in the country in order to play a significant role in development. Between 1970 to 1976, the faculty continued to be a faculty of the University of Dar es Salaam. From 1976 to 1990, the faculty was incorporated in an institution that was called Muhimbili Medical Center, which had the Faculty of Medicine on one hand and the Muhimbili Hospital on the other hand. That institution was eventually disengaged by the government into Muhimbili National Hospital and later the university institution. But it is also significant for me to observe that in 1991, the Faculty of Medicine, then incorporated within the Muhimbili Medical Center, became a constituent college of the University of Dar es Salaam. That is another transformation that uplifted the role of the faculty into a university college, what is commonly referred to as DAKI in Kiswahili. This constituent college eventually became what we now have as Muhimbili University of Health and Allied Sciences in 2007, and therefore a final transformation under the University of Dar es Salaam. So this one is not moving, I cannot. So let me just briefly summarize the transformations that took place and influenced the training of health professionals in the country. The first one that I've said was the establishment of the University of Dar es Salaam, which among other objectives was to ensure the training of professionals in various fields, the health professionals being one of them. And then the transformation of the University of Dar es Salaam, whereby constituent colleges were established, including the Muhimbili University College of Health Sciences, that is MOOCS, in 1991. Apart from the university transformations, there were political and social changes that also influenced the training of human resources, and I will narrate these in a short while. There was the issue of establishment of higher education ministry in the country, which also had an influence on promoting university education and therefore the training of health professionals at university level. The establishment of the Tanzania Commission for Universities later as a regulatory organ for universities also has had an influence on the training of professionals, in that the TCU has laid down guidelines which inform the training of various types of professionals, including health professionals, in terms of numbers as well as quality. So all these transformations have influenced the training of human resources for health in the country. The political changes that I'm alluding to include the fact that between 1967 to 1985, we had the political ideology of socialism and self-reliance, as you are all very much aware. Under this political ideology, the health services in the country were directed to ensure that priority for future development has to reflect the health requirements, also the way we generate human resources to provide health. There was emphasis on providing free health services in the country, and emphasis on preventive health services and the training of local health cadres. But unfortunately, private health services were kind of restricted during this period. Between 1986 to the late 1990s, this was a time when capitalist philosophy of free markets was introduced in the country under the so-called economic neo-liberalization. Now, in this period, the World Bank and IMF introduced what is known as the structural adjustment, and it was also during this time when health sector reform was adopted in the 1990s. And under the health sector reform, this was designed to improve the functioning and performance of the health sector and bring health services close to the people. It also decentralized to introduce high demand for medical doctors in order to oversee the implementation of programs in districts and regions. There was a lot of emphasis on public-private partnership. Ladies and gentlemen, you will recall that under the health sector reform, the ministry responsible for health was supposed to just have eyes on and hands off when it came to handling issues of health at the district and regional levels. academic medical center.
Of panel discussion. One of our own today has chosen the day to mark this day by launching a book. Is a professor from the School of Nursing. She's going to launch a book today. So right now I'd like to welcome Professor Edith Tarimo to come and speak for a few minutes about the book. Welcome to Vice Chancellor to launch the book. Karibu sana.
Mgeni rasmi, makamu mkuu wa chuo MUHAS Profesa Andrea Penn, kaimu naibu mkuu wa chuo taaluma tafiti na consultancy Profesa Bonani Kamhagwa, kaimu naibu makamu mkuu wa chuo mipango fedha na uongozi Profesa Said Abud, mwakilishi kutoka UDOM Dr. Steven Kibusi, mwakilishi kutoka chuo kikuu cha afya UDSM Mbeya Profesa Mwajabu Kosi, wawakilishi kutoka mashuleni, organizers, viongozi wateule, mabibi na mabwana, na wasalimu kwa jina la Jamhuri ya Muungano. Mimi ni mmojawapo wa alumni wa kwanza wa shahada ya uuguzi na ni mtunzi wa kitabu cha miaka 30 ya historia ya shahada ya uuguzi hapa MUHAS, yani kati ya 1989 mpaka 2019. Ninayo furaha kubwa kupata nafasi ya uzinduzi wa kitabu hiki maalum ndani ya kongamano la kusherehekea miaka 60 ya uhuru wa nchi yetu. I'm honored to have this opportunity actually. Kwa heshima kubwa, ningependa kutambua uwepo wa Profesa Paul Mela, naomba usimame. Anasimamia kwa makini kabisa uanzilishi wa shahada ya uuguzi nchini Tanzania. Alipomaliza shahada yake ya uzamili nchini Marekani, alirudi Tanzania akiwa na shauku kubwa sana ya kuendeleza taaluma ya uuguzi. Kitabu kinaeleza historia kuanzia mwaka 84 Wizara ya Afya ilipoona umuhimu wa kuwa na uuguzi wenye shahada nchini Tanzania. Kutokana na baraka hizo za Wizara ya Afya, Profesa Mela alitake advantage mwaka 1988 na kuendeleza mwendelezo huo kwa kushirikiana na washirika kutoka Chuo Kikuu cha Dalhousie, Canada, wakaweza kuanzisha shahada hiyo hapa nchini. Nakumbuka siku za mwanzoni tulibahatika kufundishwa na baadhi ya washiriki kutoka Canada ambao walijitolea kufundisha hiyo shahada mpaka kuhakikisha grupu la kwanza limegraduate. Na najivuna kutamka kuwa MUHAS kwa wakati ule chini ya Chuo Kikuu cha Dar es Salaam kilikuwa chuo cha kwanza Tanzania au Afrika Mashariki kuanzisha shahada ya uuguzi. Simulizi za wahitimu wote walio graduate banchi ya kwanza na nukuu kutoka kwa waanzilishi ambao walikuwa trained Canada kwa ajili ya kuanzisha hiyo shahada hapa, na mlolongo wa wakuu wa shule ya uuguzi na michango yao katika kukuza shule inashuhudiwa katika kitabu hiki. Maono na fursa za wahitimu zinajidhihirisha katika maandishi. Kwa sababu ya ubora wa mtaala wa shahada ya uuguzi, wahitimu wanafanya kazi katika maeneo mbalimbali ya kutoa huduma katika jamii. Ya kwanza kabisa ni kutoa huduma kwa wagonjwa katika healthcare settings, kama walimu katika level mbalimbali kuanzia certificate mpaka degree, kama washauri yani counselors in the hospital settings, NGOs and communities, kama advocates and advisors at institutional and national level, as collaborators both local and international, na kama viongozi au managers katika levels mbalimbali, na kama researchers pia, kwa sababu as direct caregivers we expect to apply evidence-based practice, na kwa hivyo tunadepend kwenye matokeo ya tafiti ambayo yatatoa recommendations ambazo ni practical. Na mwisho kabisa kama entrepreneurs, innovators katika professional, social and financial. Maeneo yote 8 yameainishwa katika curriculum na yanawakilishwa katika kitabu hiki, yakiambatana na picha na maelezo kutoka kwa wahitimu waliochagua kubobea katika nyanja hizo. Kwa miaka 30 sasa, MUHAS imeweza kutoa wauguzi wenye shahada 556 na kutokana na ongezeko la vyuo vikuu vingine 8 ambavyo vinatoa shahada hii ya uuguzi, tunaweza kuona kwa mwaka 2019 peke yake, ukichanganya vyuo vikuu vyote 8 viliweza kutoa wahitimu 816 ambao walijiunga na mafunzo ya internship, kuashiria mwelekeo wa taaluma ya uuguzi miaka ijayo hapa Tanzania. Ongezeko hili natumaini litasambaza wauguzi wengi wenye shahada nchini, na tunatarajia ongezeko la wauguzi wabobezi siku za karibuni. Muhimu zaidi ni mategemeo yangu kwamba kitabu hiki kitakuwa chanzo cha tafiti kuhusu utendaji wa wahitimu hao waliomaliza na impact ya wahitimu hawa katika healthcare system in Tanzania. Sasa niko na tafsiri. I believe that the documentation of the development and history of the BSc program will lead to an increased understanding of enormous contribution of MUHAS in advancing the nursing profession in Tanzania. And I believe this book will inspire young generation. Shukrani za pekee utawala wa MUHAS kwa kuwataja makamu mkuu wa chuo Professor Andrea Pembe, who strongly commended the documentation of the history of the School of Nursing. The current kaimu naibu makamu mkuu wa chuo taaluma, tafiti na consultancy, Professor Polinarika Mhabwa, who strongly encouraged the writing of this book from the very first day. The former DVC ACK, Professor Eligius Yamuya, who has been very supportive of this work. Mwisho, I would like to thank MUHAS for full support of this documentation. And this book is my contribution to MUHAS. Copies of the book are available free of charge in the School of Nursing on reasonable request. Honorable guests of honor, distinguished guests, ladies and gentlemen, thank you very much for your attention, and may I present the book for launching.
Naomba nimkaribishe makamu mkuu wa chuo.
Naomba kimoja.
Asante sana. Pamoja na upendeleo wale wote walioitwa hapa kwenye special request waliopewa asante waje hapa mbele pamoja na Profesa Mela. Yes, picha moja kwa wale walioitwa kama special thanks waje hapa mbele pamoja na Profesa Mela wapate picha moja ya ukumbusho kabla hatujamaliza. Hongera sana Profesa kwa kuweza kutengeneza kitabu hicho. Nashukuru sana. Kama alivyosema kitapatikana kwa reasonable request, so unaweza ukaandika reasonable request yako sasa hivi na unahitaji ili uweze kupata. Alafu Profesa anataka kuwapa pia wawakilishi kutoka UDOM and University of Dar es Salaam wapate kopi moja atawapa hapo sasa hivi. Na wageni waliotoka nje wanaweza pia kuipata hapo nje. Nashukuru sana. Naomba sasa hivi nimkaribishe mwenyekiti wa session inayofuata ambaye ni Idrisia Salamwe atuongoze katika session ya first panel discussion. Karibu sana. Naomba ni apology Professor Kamwagwa.
Thank you very much, MC. Members, sasa tumeingia kwenye panel discussion. Niombe wahusika mje mbele. Profesa Shabali, Profesa Akali, Menadi Bwere. Wahusika panel discussion. Naomba mje mbele. Kwa hiyo tuna Profesa Muhammad Bakari, Profesa Shabali, Nina Dimbwe na Steve Busi. Hapa mje hapa. So members, we just received the three keynote presentations. Now we have a panel discussion, and then we have the general discussion and the recommendations. So we have prepared some questions that we stimulate the discussion. So we start with Professor Muhammad Bakari. I think we have in the timetable, you may have read their bios. So I will not detail the bios, but Professor Bakari is a professor at MOAS. And Professor Bakari, I will start by saying that you know that in our country, like many other nations, has experienced epidemiological transition owing to a number of factors, including demographic transition and economic transition. And also this was emphasized in one of the keynote presentations. And during years after independence, Tanzania has predominantly faced the burden of infectious disease. With rapid development, the country has somehow managed to overcome some of these threats. In your experience as a senior researcher in infectious diseases who has seen these transformations, can you narrate what has been done, what remains to be done, what are the remaining challenges, particularly in the area of HIV and tuberculosis, which I believe are your areas of interest where you are conducting quite a number of things. So we start with that question and then proceed with that. Okay.
Nami naomba nianze kwa kuwasalimu kwa jina la Jamhuri. Asante sana na nianze kuwashukuru organizers kwa kunipa nafasi. But also we appreciate really what has been presented by the previous speakers in their presentations. But of this panel discussion, before I move on, I saw something during the presentation that was factual, and I think it is important to make a correction. And that was about the COVID support that was given to us. So that support, I think it is a support that was given by the family of Dr. Salim. It was not a support that was given by the president of Zanzibar. So I think this is an important part that we need to correct. So straight to the question, to share this kind of discussion, I will try actually to be pretty brief today. I respond to these questions for obvious reasons. The earlier presentations have shown very clearly the remarkable progress that this country has made on communicable diseases. Professor Kileo has shown very eloquently what has happened to, especially HIV, where the question is focused on. So what has been done? What really helped this to happen? In my view, one is the whole issue of putting up policies and strategies. And of course, based on my other experiences as well, I think we are pretty good at putting up policies and strategies. We came up with control programs, which I think contributed to the achievements that we have been told today. But the second thing is what I would call international collaboration. So we addressed infectious diseases side, not just as Tanzania alone. We are open, we invited others, and we worked together. And I think this also has helped a lot. Because it has helped in the formulation of the policies, but also in the availability of the resources that will be needed for the control of these diseases. What remains as a challenge? I would go straight to go and say that generally speaking, our capacity as a nation to deal with serious infectious illnesses that are of public health importance is still low. It's still low in terms of resources, in terms of human resource, in terms of financial resource. It is still low in terms of the needed infrastructure to address these challenges. But I think increasingly, to me, this is a challenge. We do see the negative impact of people I may call people who are having huge influence in the community, and then coming up with issues that confuse the community, and therefore we have serious difficulties in controlling infectious diseases. And lately we have realized how powerful, how detrimental actually these individuals could be in our communities. Thank you.
So I note that you have already mentioned about how to eliminate these remaining challenges. So you mentioned the negative people in the community. We need sensitization over the right information. But the other question is, what are the most important milestones that you may remember that have been in the hallmark of your career in infectious diseases that the country has gone through, and how can we learn from as we navigate through the newer challenges? Now we have the COVID-19. Yes.
I don't like to be. I really try to be reservist when it comes to COVID, but let me start with HIV. I think I'm very happy with the experiences I've gone through when it came to HIV, because I have lived through the whole spectrum of HIV when it was kind of a very serious disease, death threat, hakuna matumaini, to currently a disease that you can live. So I'm lucky to have gone through that. And I have learned a lot through that. So I remember in the 80s, in the late 80s, the medical wards would be full of HIV. 60% of the patients in a medical ward would be patients with AIDS. Very bad picture. And you really have a lot to do. Then came the aspect of being more focused and more aggressive in management of opportunistic infections. And I remember vividly the way fluconazole made a difference in some of the time. Just treating oral esophageal candidiasis and seeing a patient improve. Diagnosing TB and treating the tuberculosis, and then you see a patient improve. So that was quite an experience. But secondly, the advent of antiretrovirals. That changed the whole scenario. Okay? Changed the whole scenario. We started with antiretrovirals, which were too many, very expensive, lots of side effects, and now we have fairly affordable, less antiretrovirals with less side effects, and we see control of HIV. But the other thing is, I think it is through this collaboration with other people. The way we looked into the epidemiology of HIV, and the way we intervened in terms of vaccine evaluation. So we started with vaccine evaluation, and I'm happy that that process is still continuing as today. And I think that process of getting involved in vaccine development has brought huge benefits for this country. It has brought benefits for the institution. It has brought benefit for the country. So it was a beautiful experience, and we are doing it. The second issue, and let me talk about COVID. I think with COVID, what I have learned a lot is that as a government, there comes a time when you have to change. I think as a government, we made the right change when we said we are going to respond by being driven by science. So I think the change that Her Excellency did, forming an advisory committee and then accepting the advice, I think we are on the right.
For those testimonies. So that was a question on communicable diseases. The next question is on transformative learning. And this question is for Professor Mwajab Pos. Professor Posi, the question is that in the quiz to address the various health challenges in Tanzania, and the government has taken a number of measures to improve the quality and quantity of care workers, and this is through increasing the number of medical and health sciences training institutions, but yet these measures are still inadequate. You have been in academic environment and observed these changes over years. So the question is, what are we doing right, and what needs to be done to improve learning output and solve the human resource for health crisis? So this question I want to answer first.
Thank you very much indeed for the question. I was trying a lot to see if I can trust them. But what I can say is that we cannot say we are doing everything right, but there's a lot of improvement that has been done. There have been a lot of attempts in terms of policy, also in terms of looking at the inputs, process, and output. When you look at the inputs, you see the number of institutions. If you listen very well to Professor Liamule, you see where we were. And then also when you look at manpower, you see that there are also people who are being trained a lot, but also even the experts, not only just training, even the experts. And, we are happy, for example, we know that there are also, pacemaker, when you hear someone specializing in that, you say, oh my God, so this is where we are now. So there's a lot that has been done, but also there's a lot of increase in terms of programs. Various programs are there, and you can also see me coming from there, a daughter or a son of Muhimbili Hospital, but also I don't know where to say whether my brother or my son Muhimbili, because I'm from the University of Dar es Salaam. But you can see the way we are improving, And within the institutions also, you can see various programs that are there. So we are doing a lot there. But also, not only in the government, but also look at the private institutions. So there's a lot that we can be proud of course, increasing number of universities and so on and so forth. And also the output in terms of the students, in terms of the experts. We are now saying we might reach a time very soon where we say we don't need even people from outside because we have our own people. But the question, of course, is going to come where I'm asking through my experience and my age, as you can see, it's like, are we going to be there where our first batch was in terms of the quality? So we are looking into the quality and not quantity. But of course, we are proud of quantity, but also we're insisting upon quality. Everyone knows about that. So we have also places where people can have hands-on in terms of practicals, but also I know we're going to talk about the challenges, but really we've done so far so good, but we should not relax because we have a long way to go too.
Okay, thank you much. You acknowledge that you have made progress, especially in terms of quantities, but we still need to improve on quality. Now, specifically, you coming from the University of Dar es Salaam, maybe you could tell us briefly. Many people know the contribution of that University of Dar es Salaam has made. You could tell us, in particular in this question, what specifically the University of Dar es Salaam has done, and whether we need to improve where we are and how to improve as we move forward.
Okay, the thing is, programs that we have, and of course, I'm looking at in terms of the University of Dar es Salaam. If I don't go for MCHAS, I go for the University of Dar es Salaam right from the beginning. That most, if not say majority of the doctors are coming from the same institution, so there's a lot of contribution. But also there are programs that are there, and others are coming. For example, we see that there are programs that are new, which people are also saying, like we have to have like in just now we are planning to have a dental program for dentists. So that is also something that we are looking into. But also in terms of research, in terms of innovation, people are doing a lot of research, and you know, even when you look at NIMRI, for example, it's also our product because the members are right from the University of Dar es Salaam. So we are getting there. And even getting another branch in MCHAS, to me, you know, I don't know, well, there's a fine line there, but to me, it's still an improvement in the health sector in terms of training institutions.
Okay, thank you much, Prof. But in terms of quality, you mentioned that we need to improve in terms of quality.
Yes.
What are the measures that need to be taken for the quality of the product?
Okay, one, I'm looking at the quality and looking at their inputs. You have trainees who are there, but when you look at some of the equipment, even when you look at where to go for training, for example, I would be looking at Muhimbili or looking at MCHAS, I would want to see a training institution where there is a place where when the lecturers, when the professors are teaching, and then they want to go and show people, show their students some of the problems affecting maybe in a certain area, medical problems. Maybe they have their own kind of a hospital somewhere within that location where they can go and talk to the people and make their students have hands-on experience in the teaching, not for practicals, not, you know, during the teaching process, you can say, I have a patient there, let's go do 1, 2, 3, 4. But I would also want to see sufficient equipment, you know, in terms of student equipment ratio, something like that. But I wouldn't want to have just big numbers. I would want to see also the lecturer-student ratio. Yes, just to see. So those are some of the things I want to see because those affect quality. If you don't have a sufficient number of trainers in terms of doctors, specialists, then what do you expect? will be overwhelmed, will be overloaded, and we are not going to be able to give quality, quality instruction because, you'll be overwhelmed. So that's my thinking. Equipment, which is input, trainers in terms of lecturers and so on, but also the environment and also, of course, infrastructure. There's so many things that we need to look into.
Thank you much, Professor Post, for responding to that question. So that question was on transformative learning. The next question, the third question, is on behavior and health of Tanzanians and the role of universities. This question is directed to Professor Shabali. Professor Shabali is a research chair from UAS. And the question is, diseases are largely associated with lifestyle, behavior, but also social demographic determinants. And as a researcher in behavioral sciences and a trainer for many years, you have seen how these determinants interact with the Tanzanian population. This might have resulted in an ever-changing epidemiological landscape. Can you comment on the epidemiological transition in the face of behavioral and the lifestyle of Tanzania?
Oh, thank you, Mr. Chairman, and ladies and gentlemen. First of all, I think we all agree that behavior is a very complex concept, and its acquisition starts from the family. It's a family level at home where we learn basic things about food, basic names about diseases, how to prevent them at that level. And from home, we go into the community as we grow up. And at the community level, that's when some of us or people start school. And when you go to school, there are also models of behavior acquisition which are taking place at that level. And from the schools, which are staggered, we have primary schools, secondary schools, and then we go to the universities and other institutions where we get different models of behavior acquisition. And these are a lot of implications in health. At home, they say we do have behaviors acquired at that level, which enable us to, for example, learn about diseases and their treatment. However, as we grow up, as we move into communities, schools and universities, some of these models change, and they create a lot of challenges in the system. Just as an example, it is very difficult to explain why so many people went to see Babu and Odiondo, including some health professionals and doctors in particular. And one would imagine a mixture of the behavior acquisition from home and from communities who will have significantly influenced even the knowledge which we learned in medical schools, making people believe in things which, when you mention to any person trained in the biological model, will not understand what they're doing. And what's even more strange, you find that if you take the Babu and Odiondo as an example, the TB, the HIV, diabetes, the hypertension, which Babu and Odiondo was treating, is not the same with the TB, hypertension, diabetes, and so on, which is treated by those people who train in the medical schools. The next question is, how did our system, and that's why we're in terms of behaviors and consequences, a lot of people died because of that, of the behavioral change from our modern health system to the traditional system. What was very strange, no steps were taken despite the large numbers of people who died because of going to something which each one of us knew was wrong and no corrective steps were taken. And now, when we see these kinds of changes, behavioral changes taking place in the system, one wonders to what extent is the acquisition of behaviors which are taking place from home and in the communities where we live. to what extent can these really be modified in order to conform with some of the health-related behaviors which we teach in our institutions and which we think are useful to society. And that gap is what leads into all sorts of challenges, leading into the kinds of deaths from Zimbabwe and Yondo. And we recently also had a person who had a way of telling people we can be cured mysteriously using religious or whatever beliefs. And a few people died in Moshi. And again, that guy initially felt that he has done something wrong, he ran away. But when he came back, nothing happened. And when we are in a society where we can have such double dealings with behaviors which are detrimental to human life, it means we have quite a lot to do for us in the university in order to create the kind of behavioral changes which we think are useful to society.
Okay, thank you for the talk. So, but now, what needs to be done? Now, right now, we have faced the challenges of the uptake vaccination of COVID-19. Part of this area. So, from academic point of view, from research point of view, what needs to be done?
Mr. Chairman, I think COVID is complex, and my colleague, Professor Bakari, don't want to get into that. There are a lot of models which people use in their behaviors. And once you acquire behavior from a particular model, changing it can be complex. For example, if we are not used to, there are a lot of details which we don't give the general population from the health establishment. For example, if you tell people the probability of getting HIV for a male who is HIV negative, to get HIV infected by having sex with an HIV female is less than 1%. We don't reveal that kind of information. This information we just kept to ourselves. And the reason we don't do that is that once people get information, they may end up being fixated. Consequently, with COVID, for example, if we've told people that, first of all, it's quite possible what's going on, we can pray. And if you pray, it will be okay. And we prayed during the first week. It ended somehow. So whether it was due to praise or it was due to other changes in the environment, we don't know. Now, once we fix our minds on this kind of change, and later when the virus changes and becomes, no. Now you need to be vaccinated. At the same time, you're passing information that we don't even know how effective the vaccine is. We don't know whether if you get the vaccine, it's also possible to get infected. We do not, when you look into the level of understanding of people and what that knowledge can be translated into behaviors, what it means, it will be extremely difficult for you to come and change my mind. From you can be cured by prayers, or some of the diagnostic facilities are wrong. You use laboratories for plants specimen are being used in human labs. Me as another person, I don't understand what they're saying, but I buy and I agree with you as my model, as my leader, as my father. If that things, it will be extremely difficult to get alternative ways of doing this kind of behavioral changes. It's possible to do it, but you need techniques which are not easily available, and they may create some of the challenges which we see because of the contradictory messages which the general population is cannot easily comprehend.
Okay, thank you, Professor Deshabari. But we still need those techniques because you told us behavior is always influenced and can change.
Yes.
And if you have those techniques, at least that we can apply, because there will be many challenges coming. So I think from science point of view, from professional point of view, I think we have the responsibility where we can have models that can influence positive change to address the health problems that we are facing. Okay, thank you very much, Professor Deshabari. The third question is on the health is to Dr. Bernard Mwere. The question is, as an upcoming scientist, I told you an upcoming scientist and aspiring leader in the medical arena, you have witnessed economic and research transformation in the country. These are not limited to infectious, non-infectious, but also in maternal and child health. So the question is, what have been the biggest achievement in the areas where we are not doing well in this aspect? Thank you so much.
So much, Mr. Chairman.
Thank you so much, Mr. Chairman. Well, before tackling your question, I would really like to pose my special acknowledgement to the first three panels presented. Actually, the Professor Jafet Kileo, who presented Epidemiological Transition, the second presenter on economic transformation, the very last presenter, Professor Mua, on education transformation. Well, before addressing issues on maternal health, infectious and non-infectious disease, I would really like to remind on the Abdel Omran model on epidemiological transition. Well, back in 1971, Abdel Omran, as one of the philosophical epidemiologists, described the epidemiological transition that whenever there is disease changes, there are some changes in the disease pattern. There tend to be also changes in death rate as well as fertility rate. And these at the end will definitely affect the demographic picture of a certain community. Now, Abdel Omran, not only he became famous as describing the epidemiological transition, but rather he gave an opportunity to describe the way these diseases could change. In 2005, the model was further published and discussed, where there was elaboration of the way several hundred years before Christ, most diseases were related to famine, hunger. And this was the age actually which was described as the age of pestilence and famine. And then later on, hundreds of years after Christ, there was another age. Of course, this was an age of disease of epidemics. Mostly infectious disease was the main cause of disease. And by these particular patterns, the life expectancies also were changing. In the first age, it was less than 30, but in the second phase, it was ranging from 30 to 50. But according to the migration, population dynamics, there was a change from infectious diseases to another form of diseases, which were called man-made diseases or degenerative diseases, which we have today. Now, the same model further elaborated that despite the changes to patterns of the diseases, still one need to identify what could be all the main causes of these pattern changes. And Abdel Omran emphasizes that there are actually ecological factors that explain how diseases changes. In the second phase, he could explain that there are social, economic, political, and cultural factors that explain the changing patterns of disease. He described the public health, the way diseases are managed in the facilities. So when we discuss the 60 years of independence, one will notice that the health sector reform that was presented by the second presenter, one might even say maybe the health sector reform provided revolution of health sector in Tanzania, because it not only it offered the change in managerial, where we saw that there was decentralization, the district council could take a lead in managing a health system. But not only that, there was financial revolution, as well as the main system that the vertical, talking about from the ministry to the dispensary. But again, I think it was several years, 1 year before the end of Millennium Development Goal, Professor Fares, professor who is also a health economist, reputed that health sector reform was not really the main the main explanation for achievement of Millennium Development Goal. Yes, we know that the child mortality rate has declined, infant mortality rate has declined. We have almost half the death rates due to HIV, as Professor Bakari has explained, and also we have seen that the clinical admission due to clinical malaria, in fact, even the attendance of patients with clinical malaria facilities has declined. But the question is, was it really the health sector reform as the main explanation to this particular pattern of achievement? The answer will not be directly. And Professor Mjinja, actually, who presented this particular topic, refuted that health sector reform really just provided the basic kind of the platform upon which most of the evolution were occurring in our country. Yes, in maternal and newborn health, we have seen that we have built more than 67 district hospitals. And I think up to last year, to 2020, we have about 8,700 facilities registered as facilities in Tanzania. 62% of those are public facilities. And again, I think it was 2018, 2017, 67 facilities as the district hospital were implemented. But again, ladies and gentlemen, if you look toward the model that was described by Donna Bedian, the model of quality improvement, Donna Bedian in 1967 explained, saying that if you want to improve the quality of care in any setting, you need really to invest in the infrastructure, the structures, and then you need really to improve the processes so that you can see the outcomes. So what has happened in our country, actually, in maternal health, really, there has been a significant improvement in health facilities, tackling maternal issues when we institutionalize the comprehensive emergency obstetric and newborn care. Right now, as we are talking, we know it was in 2013 and 2015 where Tanzania went through the establishment of cesarean section and blood transfusion in health centers. As we speak right now, actually, there's a change from 30% women who were pregnant women delivered in health facilities before 2010. But in 2015, the Tanzania Demographic Health Surveillance presented the data that there was a 65 increment of mothers delivering in health facilities. And not only that, proportionally, we talk about, not only that, I think even when you count numbers of mothers who were delivering in facilities, only 30 women were delivering in health centers before 2010. But in fact, in 2015, we could see that we are talking about 166 mothers delivering in health centers. So this particular achievement, if you look at a glance, one might say, I think Tanzania has made a remarkable improvement in the system. I would say yes, but this improvement, I would say, are mainly in the infrastructure, in the structures. But if you look on the processes, in the last 2 years in there, I was doing a rapid appraisal of causes of maternal death there. I was shocked that obstetric hemorrhage is still the leading cause of maternal death in there. So what we learned from this is that really we have structures. Yes, we have a bit improved on the availability of healthcare workers, but are these healthcare workers skilled enough? Do we have the right attitudes of healthcare workers during provision of healthcare? And if you look at this particular block, which we call the process of quality of care, one will see that we haven't really learned from mothers. We haven't really asked them what are the issues. So I'm saying, as a way, if you ask me what we need to do, I would simply say we really need to improve quality of care. But again, we need to focus on patient-centered quality of care. And so to say, we need to focus on patient-centered research so as to improve the quality of care, institutionalize quality of care in our health system. Thank you so much.
Thank you much. Where you have indicated the challenges, the progress that are made, but also you have suggested what needs to be done. So the last panelist is Dr. Stephen Kibus. Is on health system response, and I believe the presenter who has just talked about this, I think he has also touched some of the areas that there are no question. But the question is that Tanzania as a country has gone through phases
which have been responding to various challenges that we have had, and some have been successful. But those phases, some have been successful, but some are not so much successful. Now, can you narrate the health system challenges we have gone through as a country, and also maybe you may propose what are the application measures?
Yeah, thank you very much, Professor. First, I should just say a number of issues and challenges have been mentioned in the earlier presentations. I think I can highlight Professor Kileo's presentation and Dr. Vago's presentation. They kind of talked broadly on the issues that our healthcare system have been facing. But I will speak on a system-oriented kind of thinking. If you look at our country, from independence, there are a number of issues that emerge and has been defining our healthcare system. And of course, in that case, then I will be able to mention about the challenges. There are issues about, we have had a struggle to balance between a pursuit for universal coverage vis-a-vis health system financing. So how do you balance the two? When we just got independence, we embarked on building health posts, building health facilities, villagization to make sure that people are brought together, and then you can build the health facilities close to the people. The struggle was there to make sure that there is some sense of universal accessibility to the healthcare system. And you speak of free medical care. We used to have those kind of stuff. So ranging from 1960s until almost 90s, after the structural adjustment, that's where we were forced to come up with the health policy, and this health policy kind of introduces issues of cost sharing and user fee. But again, today, we are, user fee and everything, it's a kind of, they put more burden into the poor or to the lowest quantile population in terms of wealth. So the poor actually were the majority. They ended up being, shouldering the cost of running the healthcare system, and it was not practical. So we started to come up with some innovative ideas on how we can be able to finance our healthcare system. But in mind is the struggle wanting to have everybody access the healthcare system, and this is enshrined in our ideology, being a socialist country. So recently, I think in the 2000 years, we can see some examples. I think it was in Igunga where somebody tried a model for community health funds, and this has been rolling. Now we have the modified or improved health fund, and now we are speaking of universal coverage. We needed to have a national health insurance that will cover for everybody. So you can see our struggle has been there since independence, based on our ideology, wanting to have a socialized healthcare system where access to health is based on need rather than people's ability to pay. But again, we come to the second challenge that there are issues with the finance and sources of finance. We have a very small and maybe not well organized, what we call a formal health sector, and look on the other hand, the informal sector is still just coming up to be able to contribute meaningfully on supporting the healthcare system. So the issue of financing also is another major challenge. Another thing, the structure, like Dr. Mbwede is mentioning, there have been a struggle to make sure that our health system is decentralized. This is also another thing. I could cite examples during independence when you have villageization. So we had the idea of decentralization, but mainly, what can I say? Decentralization by concentration. You bring people somewhere, if they are there, then you invest on health so that they can access. But this is again, if you read the books, they say it was impractical. For example, 1967 is when we started to come up with the issues around this. I mean, like a decentralization act. Or if it's 60s, late 60s or early 70s. But again, it took like 11 years of failure of such a system because the local government they didn't have the capacity to implement the policies at the national level. So we had to move back to until 2000 something when we started talking about decentralization by devolution. And I think that the issue of building the capacity of health of the local government, it become part of the agenda as part of this decentralization. Instead of just pushing the agendas at the central, while the people at the local, they are not prepared, at the end, the whole system is to fail. And so currently, we can see we have like at the president's office, the ministry responsible for local government and the regional administration of some Pura. They have a directorate that deals with the implementation of health services. And somehow we can see there's a lot of capacity building going on almost every aspect. Even on issues of finance, now we have facilities having their own health financial account, and they're being empowered to handle the accounts. They can do planning and project their expenditures. There are issues around the accountability and the governance. So you see, at every facility now you have the health facility governance also that involves the community in decision making, and at the district level the same. So you can see some structures being laid down and the whole idea of decentralization being implemented. But this also has been one of the challenges throughout our history, trying to attain a functioning, decentralized healthcare system. And another issue, I will speak just there is also a challenge about the balancing curative and preventive. If you look at the investment right now, we're investing only in building hospitals and everything. And this has been just the agenda since independence. So our responses to infectious disease has been more, I don't know what I say, taking the issue of COVID-19. The way we responded is because we never give much accounting to the science around the prevention of diseases. And we might have a structure, but the response and the commitment in terms of investment is not put much on this. And this is the more of the understanding that we have. Another issue is our healthcare system has somehow been influenced by external forces or external influences. If, for example, when we just got independence, the idea of health care for all is very vividly right there in this country. But it took years until 1978 when the world came up with the Alma-Ata Declaration, and then it was as if we started talking about health care for all at that time. Tanzania, we have health care for all since that time. And look at the response for HIV AIDS. In 1983, reporting the first case, but coming with even a national strategy, 2001. What were we doing all this time without a national strategy to address HIV? You can see external influences directed us to deal with structural adjustment and the issues of health sector reforms. So there are issues there which kind of somehow forces external influences. They kind of maybe they're helpful in terms of because we have donor dependence, but again they tended to kind of mislead us somehow. I don't know if misleading is the right way. They also focus on some of the issues actually we believe in even from the very beginning. But you can see these things, they're recurring and they're still there even today. There are challenges also in measuring performance, emphasis on the outcome, rather than, as Dr. Mbwe mentioned, the processes and the structures. We have no data that really shows trends of improvement in terms of the supporting processes and the structures. So, for example, you wanted to attain good health. We can report the mortality and morbidity, but the processes that went into the process, I mean, the level of investment and commitments in the process to attain such an outcome, they are not really being well reported. I will just end here because, I mean, you can instead of speaking, make your presentation as a discussion.
Thank you very much, Dr. Kibus, for those details remarks on the health system response. So we have reached the end of the panel discussion. So I believe some people may have questions or comments that may arise from the three notes speech as well as the discussion that we have just had. So if you have a comment, make it brief. You have just 5 minutes for this, then we are going to wind up. So I know that everything was very, very clear. Yes.
Thank you very much, Mr. Chairperson, and wonderful presentations from every speaker today. My question is to Professor Kileo, our Professor Emeritus, and with regard to the presentation of the epidemiological transition. What I've noted is, although we are moving in cycles of infectious diseases and pandemics, and the future is not really promising with regard to pandemics. I mean, the picture that we have seen this and last year, it's most likely going to repeat again and again and again. So my question with regard to the previous, or to the models that are available, what needs to be done? What can we borrow from your experience on handling these infectious diseases in the past, on handling the newer and perhaps pandemics or infectious diseases that we may not be aware of, rather than just trying to reinvent the wheel every time we are sort of in similar context or situation.
Okay, so that question is taken by Professor Kileo. You respond. Any other question? So yes.
Thank you very much.
Thank you very much, Mr. Chairperson. My question goes to Professor Muhammad Bakari. It's about infectious diseases. According to the current data that I have here, we are listed in position 22nd among the countries which have more deaths due to the rare diseases. But we know these can be prevented by merely simple measures. What do you think is the problem that we are still recording very high number of deaths due to the rare diseases? Thank you.
Okay, thank you very much. So we had 2 questions. It's the end of the questions. So let's the presenters respond. So it starts with Professor Kileo.
Thank you very much, Mr. Chairman. I think the question is really, I would say it's simple to answer that question. But the problem is, are we going to adhere to that? The thing is, we are going to control all these diseases that I've mentioned, starting from smallpox, cholera. We're going to control cholera. Right now, I don't think there's a case of cholera in this country. We're going to control tuberculosis, for sure. We're going to control HIV, for sure. But the problem is, new diseases are going to occur, for sure. We know that. COVID-19, we didn't know anything about it 2 years ago, but now we have it. And it is predicted that we are going to have 5 to 8 similar diseases like COVID-19 in the coming decade. Of course, some of these diseases will be very mild and unnoticeable, and we cannot even detect them, but they will be in our communities. It's only the very serious diseases like COVID-19 which we shall notice and take into account. So we have to be innovative and create new interventions, new methods of dealing with such diseases. As I said, MUHAS and Sokoine University have already come up with an approach that has started working using students. We cannot have adequate number of human resources in this country in the coming 30, 40, 50, 60 years to come. And you know why. So, universities, colleges are training students all the time. These students are a very strong workforce, which has been inadequately utilized so far. Let us use students to work in communities during their vacations. They will be able to control these diseases. For example, rabies is a disease that not only the Ministry of Health can deal with. It's a disease that can be dealt with livestock ministry and wildlife and also Ministry of Health together. Vaccinating dogs is not an issue of the Ministry of Health. We've been with rabies for a long time, and we shall be with rabies for a long time to come if we don't use models of students to go out there and vaccinate dogs. In the districts, there's hardly any personnel for vaccinating dogs. Kilosa district, for example, sorry for taking so such a man. Kilosa district, for example, they could not vaccinate more than 600 dogs in 1 year because there's no personnel to vaccinate the dogs, because there's no vaccine to vaccinate the dogs. But when we went to Kilosa with the 50 students, they were able to vaccinate 2,000 dogs in 10 days. Of course, we didn't control the epidemic there, but this was only one step towards the 2030 target for eliminating rabies globally. And so, with this kind of idea, we've already talked to all the involved universities. The Vice Chancellor is here. He knows about it. That universities can release students during vacations to go out there and vaccinate dogs. And the government of Tanzania now, I'm informed, the process of manufacturing rabies vaccine. It's cheap and it's very effective. So we shall not be exporting the vaccines we're going to manufacture. We shall be using them here to control rabies. That's only one example. What about brucellosis?
Thank you so much.
Thank you so much. I'm sorry for taking so long, but we have to be innovative, Mr. Chairman.
Thank you very much. Yeah. Thank you very much. Yeah. The question is about the ranking of this country in terms of cholera. Let me say I'm not aware of that information. I don't know what is the source of that data. And I don't know what kind of time period. But what I can say is we did score fairly poorly based on the cholera epidemic. But I think after that time period, we must be doing better because it is obvious that childhood diarrhea was a problem.
Okay, thank you. Thank you very much. Oh, thank you much. Leaders, can you clap for them? I think we have reached the end of this session and we are winding up. So I'm told now the next session is for the summation. So the presenter will come. I do that for you, MC, if you don't mind. So the one who's going to make a summary. So if we might make it short in 4 minutes, we shall be happy because we're out of time.
Thank you very much. Thank you very much, Mr. Chairperson. My job now is very easy, actually, is to take you quickly through what has been discussed here in order to gain an insight as a take-home message. So, several issues have been discussed, but I will quickly point out a few. One was about the increase in population, exponential increase, which is now ranking up to 59.5 million according to National Bureau of Statistics and 62 million according to WHO. Then there is also increase in life expectancy. We are now for females 65.8, for male is 62. However, I should point out that this is also not matching the rates or the life expectancy in other countries. If you want to run, compare with others or compare with time. So we were in position 129, but now we have dropped up to position 150. So disease epidemiological transition, we heard about cholera and smallpox epidemics, also HIV, tuberculosis, as well as malaria. And we also discussed about IMF embargo on employment, which actually led to a decrease in human resource for health, as well as reduced expenditure on health, and our country's health system also was affected. There is an even distribution of health, human resource for health. Not just an even distribution, there is actually a mismatch also with the population. We heard now we are up to, doctor-patient ratio is 0.2. That is very low as you compare to international standards. Then we were also taken through economic growth, and we are told now the country is growing. The economic, in terms of GDP, is growing at the rate of 6.5 to 7. Then we were also taken through key mortalities, and we saw that infant mortality rate, neonatal mortality rate, and under 5 mortality rate, at least the country or the health sector has done well, but we still have problem when it comes to maternal mortality rate. We are now having or recording 556 deaths per 100,000 live births. This is significantly high as compared to countries which we were together 60 years ago. Malaysia, for instance, is recording only 29 deaths, Gabon 160. So we still have to do more on this area. And we were also told the importance of investing in adolescent education, particularly girls, and also invest in development of human resource for health, And we also have to see whether our health strategic plan is really working, because 60 years have elapsed and we still have only 12 medical universities, actually only 3 public universities. We cannot compare with any other country. We are still lagging very far behind. And maybe I take it as a call to the government and other stakeholders, not just to increase the enrollment of medical students in these existing universities, but also consider having new medical universities. We can have Namtumbo Medical University, Biaramulo Medical University, and so forth. This is happening in other countries. Actually, every district or every region has a medical university. Now, given our population increase, I think we need also to invest in this area. So there was also a discussion, panel discussion, and we had a response about changes or epidemiological transition of communicable diseases and collaboration that helped to decrease the cases in terms of incidences and prevalences. But we also saw the challenges, including low capacitation or low capacity of the government, and also confusion or misinformation given by those who are trusted by the communities when we are in any pandemic or epidemic situation. Then Professor Post was explaining about the need for health, human resource for health and social welfare, and what we need to do to attain the quality. You can attain quantity, of course. Even the quantity itself, we have not reached where we are supposed to be, as I indicated earlier, that we still have a very low doctor-to-patient ratio, but also she insisted on the quality and gave some insights, which included having equipped teaching hospitals or facilities, then increasing the teacher-student ratio, and so on. Then we were also taken through negative effects of harmful behaviors on responding to infections or diseases and how they can affect our scientific knowledge. This was covered by Professor Al-Shabari. And Dr. Mwele was explaining about the epidemiological transition model and the health infrastructure. And he insisted on prioritization, and he gave examples of, for example, now the government is really trying to build new health facilities, and he even quoted the number, which is significantly high, but we are still recording very high maternal mortality rate because we are only targeting only few. Maybe we are targeting hemorrhage and maybe obstructed labor, but how about infections, hypertension, and unsafe abortions and other causes? Are those people working in those areas really trained to tackle these challenges? So that was what we discussed today, and I believe every one of us here has seen where the country in terms of health sector came from, where we are now, and what we should do to reach where we want to be. Thank you very much.
Thank you so much, Dr. Chua, for that summation. I think you deserve another round of applause. Now we have come almost to the end of this program. One more thing, I would like to welcome the DVC PFA to come and say a vote of thanks and wind up this session for today.
Vice Chancellor, Professor Andre, Deputy Vice Chancellor responsible for academics, research and consultancy, Professor Apollinaire Kamagwa, representatives from University of Dodoma, Dr. Stephen Kibusi, representative from University of Dar es Salaam, Muchas, Professor Majabu Osi, the panelists, the keynote speakers, Professor Emeritus Japhet Cleo,
Dr. George Rohago and Professor Ligis Liamuya. The panelists, Professor Mohamed Bakari, Dr. Kibusi, Professor Kosi, Professor Lishabari, Dr. Mbwele, deans and directors present here, members of MOHAS community, students, invited guests, media. I think my job is very small. I've been assigned to give vote of thanks. Nawasalimu kwa jina la Jamhuri ya Muungano. I'm sure I must be very tired now. You just want to go. Let me take this opportunity to first thank the Vice Chancellor for sparing his time to come and grace this occasion on behalf of the Minister of Education, Science and Technology and the Commissioner. We also would like also to extend our sincere thanks to representatives from University of Dodoma and MCHAS for working very closely with us, collaborating with us in this symposium. Please extend our sincere thanks to your Vice Chancellors. I would also like to thank the organizing committee led by DRP for the wonderful organization of this symposium. Let us give them a round of applause. Also, sincere thanks. I would like to congratulate the keynote speakers. Again, let's give them a round of applause. Also, the panelists for a very interactive discussion, really discussing where we are, where we came from, where we are, and where we are heading. Let us give them a round. Obviously, if you have been listening to the presentation that we're done here, we have accomplished significant progress since 1961. A lot has been accomplished nationally. We started with 10 students who were training as clinical officers way back in 1963 as Dar es Salaam School of Medicine. But today we are a fully fledged university with enrollment of about 4,000. We have total students of about 4,000. A year we enroll about, actually more than 1,000 undergraduate students and almost 690 postgraduate students. So certainly significant progress have been accomplished over the 6 years. We have 16 undergraduate at MOHAS now. We have 81 postgraduate programs, including Master of Medicine, MSc, super specialization, among others. So certainly significant progress have been made. Wouldn't like to be another panelist or speaker. So with those few remarks, let me take this opportunity to once again thank all of you, the participants, students, faculty, professors, the panelists, the keynote speakers, for a very well done symposium. Let me again welcome you tomorrow. We have MOHAS, we have MOHAS Alumni Day. Please attend, it's our day to meet, network with colleagues, students, okay, of MOHAS. But also I would very much encourage you to attend the graduation ceremony. We have 15th graduation ceremony on Saturday from
from 9 a.m. So please attend. We as faculty, as staff of MOHAS, we should be in the forefront to participate in these important events. But we also have inauguration of East African Center of Excellence in Cardiovascular Sciences on Monday, 6th December at Tanzania campus. The launch will be graced by His Excellency, the first Vice President of the Revolutionary Government of Zanzibar. So please, again, you're most welcome to attend. It's our event again, so it's important that we attend. With those few remarks, I wish you a wonderful afternoon, and thank you so much.
Thank you.
Thank you very much, the DVC PFA, for that. We have just one more, we want to take one more picture. I'll ask all the presenters, the high table who were before and the presenters, and to come in front so that we can take this picture here. The one who were in the high table, the presenter of today, the panelists, and our colleagues from University of Dodoma and the University of Dar es Salaam. We can take this one final picture. The rest of you can just moving back, but the rest you can come and here. Also the DRP, please. Naomba na DRP uwe katika hii picha hii. Naomba presenters, ninaomba our collaborators from University of Dodoma, University of Dar es Salaam, their campus, the presenter, the panelists. Kama kuna dean and director, kama kuna dean or director yoyote, dean or director, ningeomba pia na Professor Edith, please come to this picture. If we have any dean or director from MOHAS also can join us. A dean or director from MOHAS. Asante sana, hiyo ni picha yetu nzuri ya ukumbusho. Nashukuru sana. For those who I was told that the books are outside. You can take. For those who are here today, you can get a book at the door. Seriously? Wait,